So, good morning, everybody. We are here on day 2 of the Hepatitis Scotland online conference, Living Experience, Patient and Peer Perspectives. I'm Norma Westland and I'm the Programme Manager at Hepatitis Scotland. So, if you missed yesterday's session on Hepatitis C and new treatments, the talks have been recorded and they'll soon be available on the Hepatitis Scotland YouTube channel. So, if you've missed it, please feel free to check in there. Today we're going to be focusing on a survey that was undertaken to look at injecting equipment provision, and then we're going to hear some more about volunteer experiences. So the conference has been made possible by the volunteer peer researchers with Hepatitis Scotland, and they've undertaken these 2 pieces of peer research. Bringing up an agenda for today, so we're going to showcase, as I said, the initial results of the IEP scoping exercises, where peer researchers have conducted a survey of IEP users' experience during COVID. It looks at injecting equipment provision, drug use patterns, harm reduction, and changes in services relating to bloodborne viruses and wound care. Following that presentation, we're going to show a discussion between harm reduction workers and service user, and then that will be followed by a live question and answer session where the two staff involved will answer any questions from the audience. After that, we're going to go on to look at the peer research volunteer experience, with a video showing their expectations of volunteering, the reality of it, their feelings and any benefits and opportunities that they've gained from being a volunteer. Again, that will be followed by a live question and answer with 2 of the peers answering questions from the audience. And then finally, we're going to round up the day by showcasing the Scottish Drugs Forum e-learning training opportunities on Hepatitis B and C. And also we're going to be promoting a new booklet on Hepatitis B. I'd just like to say, so anybody attending can submit questions, and we definitely encourage you to do that throughout the webinar. There's a questions tab on the control panel on the right side of your screen. Billy Hamilton, our Community Development and Involvement Officer with Hepatitis Scotland, is going to join us for the live Q&A session, and he'll summarise the questions that you've submitted and ask them with the panel. So, without further ado, let's get started with our first presentation. Kate Lindsay, a user development worker, is going to share the initial results of the IEP scoping exercise.
The presentation today covers the initial findings from the survey, as we're just at the very early stages of analysis. So this is a fraction of the data that we've gathered. The full report will be presented at an event later in the year. So in turn, we looked at service provision. The survey was designed to explore participants' experiences of using services during lockdown and to find out what services were doing well and what could be improved. So we explored participants' experiences of substance use, injecting equipment provision, opiate replacement therapy, BBV testing, wound care, and general well-being during lockdown and the support that was available through services at this time. The target population was people who were currently injecting drugs or who had been injecting drugs since the restrictions came into place in March 2020. In total, we carried out 62 surveys. To access participants, we engaged with services that continued to provide a service to people who inject drugs during the lockdown period. Without the cooperation of these services, we would not have been able to recruit participants due to the restrictions. So a massive thank you to the services that supported us and the individuals that are involved in that. So services referred potential participants to us with their permission, and we then contacted them by phone to provide them with information about the survey and to gain informed consent. The survey was then carried out over the phone during a 3-way call between a peer researcher who asked the questions and myself or a colleague scribing. Participants were provided with a £20 supermarket voucher as a thank you for taking part. This was also delivered electronically unless a participant requested it to be posted out. So as I said, we spoke with 62 people in total, 44 men and 18 women. The majority were white Scottish, that's 54 of them, and with 7 white British and 1 Asian Indian. In terms of age, the majority, it was actually 54. The slide has a tiny error on it. It's 54 people were between 31 to 50, and 2 were aged between 21 and 30, and 6 were between 51 and 60. 49 were currently injecting drugs, and 13 had injected drugs in the last 12 months. So when asked when did you last inject drugs, of the 49 participants who were currently injecting drugs, 17 had injected on the day that they completed the survey. 21 in the past week, 2 more than a week ago, 8 more than 2 weeks ago, and 1 more than a month ago. So more than half our participants injected drugs in the week previous to the survey, and slightly more than a third had injected the day of the survey. When asked how their drug use had changed during lockdown, 27 participants, which is about 44%, reported that their drug use had not changed during lockdown. 14 participants reported their drug use had reduced, and for 9 people it had stayed the same. 7 said their drug use had stabilised, and 5 reported having stopped taking drugs at some point during the lockdown. So when asked about whether they had difficulties accessing drugs to inject during lockdown, 45 participants said no and 16 said yes. 1 participant didn't answer this question. Substance use during lockdown. When asked what drugs they injected during a typical day in lockdown, 54 people injected heroin or other opiates, 27 had injected cocaine or crack, and 19 people had injected both heroin and cocaine. Of the 46 people who had used benzos, 38 stated these drugs were illicit, and 27 mentioned using street Valium in particular. And of the 54 participants who reported injecting heroin, 40 of them reported also using benzos, and of this number, 32 stated they were using street Valium. This is covered in a bit more depth in the discussion that follows the presentation. So opiate replacement or substitute therapy. 55 of the 62 people we spoke to were prescribed opiate replacement or substitute therapy. We asked whether this had changed and how during the lockdown. So of the 55, 34 had no change to their prescription, 9 had their dose increased, and 6 had it reduced. 2 people had been newly prescribed ORT during lockdown, and 3 had had their pick-up times changed at the chemist due to help them accommodate social distancing. 1 person didn't provide information on any changes to their prescription. So overdose prevention. 19 people reported overdose or coming close during lockdown. Of those, 10 had required an ambulance and or visited hospital due to this. So in terms of naloxone, almost everyone, 61 people, had heard of naloxone. 1 person didn't answer the question, so we can't say that they hadn't heard of it, but we can't say they did either. So of that, 49 people reported having a naloxone kit, and 4 people live with someone who has a kit. So 37 of the 61 had received that kit during lockdown, and 16 had used naloxone in someone during lockdown, and 3 had naloxone used on them during lockdown. Injecting equipment provision. 58 participants had used some form of an IEP service in the last year. 26 mostly got their equipment from the IEP service, 32 from the chemist, 2 from friends, and 2 participants didn't answer this question. 49 people reported they had no difficulties in getting sterile injecting equipment during lockdown, and 34 had reused their own injecting equipment during lockdown. They stated that they were reusing their own equipment rather than sharing equipment with others, and most reported that this was a one-off and not a regular occurrence. So BBB testing and treatment. 37 people had requested a BBB test during lockdown, and 32 had been tested. 24 had received their results, 15 were negative, 3 had completed treatment, 2 are currently receiving treatment, 2 are about to start treatment, 1 had cleared Hep C and 1 had not yet been offered treatment. So it was clear that access to BBV testing and treatment had been impacted on by the COVID-19 restrictions, and this again is covered in the discussion later. So wound care, 21 participants had developed injecting wounds during the pandemic. 13 of those had been seen by a health professional and 8 hadn't. Again, this is covered a bit in the discussion later. Next slide, please. So as I said at the beginning, this is only a fraction of the data that we have. We thought it'd be good to include a few of the positive things that participants said about what services had done well during the lockdown. So some of the comments included, when you need to talk to someone, they're always there on the phone. I like the phone calls better as I feel anxious about speaking to them on the phone. They kept the care the same and they had lots of PPE and didn't make me feel bad. They just did well in a difficult time. I can phone my addiction worker and she changes my prescription and I pick up weekly. They deliver clean equipment now. And finally, there were a few suggestions on harm reduction measures that could be put into place. A safer injection course, as I'm not very good at it. Get trained in how to inject safely instead of getting conflicting information. That would stop so much harm. We need training in naloxone. I had to use naloxone on a friend, but was really worried about using it and had to get my brother to talk me through the process. I now have the nasal spray and testing centres should be opened. So that's the findings so far. Thank you, and I hope that's provided a bit of a background for the discussion that's later. Thank you.
Thank you so much for that, Kate. Really interesting findings there and definitely some food for thought moving forward. So following Kate's presentation, we're going to look at a discussion about the main findings. So Billy hosted this discussion and he was joined by Claire Longmuir, who's a harm reduction coordinator at Simon Community Scotland, and Elaine Elder, who is an IEP worker from MELD in the Lothians, and finally Pete, who uses IEP services. After this discussion, we're going to have a live Q&A with Claire and Elaine, so please submit any questions you've got in the questions tab. Thanks.
Hi, I'm Billy Hamilton. I work for Hepatitis Scotland, and we're just going to have a discussion about the presentation about the IEP stuff. So it's just to explain, this study was about finding out how effective harm reduction services have been for people during COVID, and what's working well, and maybe what's perhaps can improve, and the changes that maybe have been made with services. I was looking at the demographics for everybody. I mean, just 44 males and 17 females, and it was mainly the 31 to 50 age group, and predominantly it was white Scottish, white British, with one Indian guy. But is that the kind of general population you would think, Elaine, that you're working with?
Yeah, aye, definitely. I mean, I kind of looked at the service users on my list, and I predominantly we're seeing, so I had 56 on my list, and out of that we had 36 males and 20 females. And it ties in with the stats of the data found in the NESI study as well, that we're definitely services are seeing an ageing population, so it definitely ties in with what I'm seeing.
And Claire, what I'm kind of interested in here is as well, I know the Simon community have got specific women projects. Do you think that women have any particular barriers that towards accessing IEP? Maybe not in your service, but in general.
Yeah, interesting. I was interested in the data that came through your studies. I suppose overall it does match what we see in terms of that mix of demographics. So Simon community obviously work with people who use drugs and who don't use drugs, but generally overall we probably work with more or see more males than we do females. But you're right, we have women only services. We've actually got 6 women only services across Scotland. So we do a lot of intensive support with women. I think there are definite barriers for women accessing IEP. You know, women generally face greater stigma, greater discrimination, might not want to go into chemists because of the impact that might have on children or access to children, or maybe worry a bit more about being able to speak about their injecting drug use because of the impact that might have in other spheres of their life, or might send somebody else into the chemist. That's kind of what we've heard, is that they might not go themselves, they might send someone else, or they don't really want to be seen going into the chemist for IEP. So yeah, I think there's definitely specific challenges for women accessing IEP, and I think one of the big gaps we have is we don't have necessarily women-only spaces. So, you know, a lot of the IEP services are designed as being gender neutral, and maybe don't take that more gender-specific view on what women need specifically. And that certainly kind of came through for us in the last year. Certainly since we've been introducing more IEP within our core service provision. So that would kind of be my reflections on it anyways.
13 people out of 61 that have injected during lockdown no longer do so. Or maybe some are smoking or have stopped injecting altogether. Is that what you sort of feel as a service user? Or, 'cause it's quite a big proportion. Does that mean harm reduction's working, or is that your experience?
Personally, it's no. I'll just quickly read you the answer that I put. I started off. I would say that the number of people who injected recently would probably be actually more higher, indicating people were saying they weren't injecting when they were. It may be false, but I think due to the way that people are, a lot of people tend to exaggerate, making out that, you know, I didn't inject as much now as I used to, or I've stopped injecting and started smoking, when that's not in fact the case. It's especially if people are either on their way to stopping or they're trying to cut down. I maybe be wrong, because I didn't mix with a lot of other users. I'm a pretty private user. But as far as I know, the people who inject are very rarely smoke it. Me personally, being an injector, I never ever smoke it, because I just didn't get the desired effect. Obviously, starting smoking, once I started injecting, I feel that smoking's a bit a waste. Even if the only time I would even consider smoking it myself is if I didn't have works there. And even then, if I was in withdrawal, I'd probably wait till I had access to works. But now that I'll digress later on, but now that works are getting delivered to the house, I can afford to have a box there, you know, as opposed to no having access. I've always got access now that they get delivered to the house.
Aye. What about yourself, Elaine? Do you feel it's just a consistent that people who are injecting, or do you think there is people like are reporting that 13 people have said that during lockdown they've actually stopped injecting?
I think from what I've seen, there's definitely, with the people I work with, there's definitely been an increase in injecting at the beginning of lockdown and during lockdown. I was run off my feet, giving out thousands of needles every week, and I think at the beginning it was a bit of maybe panic mode. I don't know if people were thinking that supply was going to be affected or not. I think now I'm seeing a drop in use. I'm definitely not giving out as much equipment as I was. So there's definitely change coming, I think, for the people I work with.
And the other thing I was looking at, I was saying it'd be fair to say the public's impression that people who inject drugs do it every day. In this study, there was 17 people that day who was injecting, and then when you took it out to the week, it'd be 28, another 28. So basically half the people would inject that week. Again, Do you think that's fairly representative, or is it people can't afford to inject every day, or do you think harm reduction might be working, that they don't need to inject every day? Maybe ask you, Claire.
I think it's a real mix depending on the person. I think for some people they will be needing to use every day, it might be injecting every day, but for some not. And you know, certainly from the conversations that we've been having around cocaine use, I think it's to do with cost, and if we've got access to money, and then if we've got access to being able to obtain those drugs, then obviously then the use will be higher at that point. But I think it's a real mix depending on where that person is in their life at that particular point.
What would you say about that, Pete? I mean,
I'll totally agree with her. I'd definitely say that 99% of it is economics. You know, if it's a full-time drug user, a full-time addict, 99% of it is regulated by your finance. Certainly in my life, most users would use Libre Day given the option, unless they're committed to reduction or stopping in some way. If finances weren't a restriction, they'd probably be injecting a lot more, in my opinion anyway.
And we're looking at the drugs that are used. So, I mean, heroin is still the biggest drug, 54 people. Cocaine and crack, 27 and 19 both. Do you think there is a movement towards more injecting cocaine?
I think we've found small pockets of East Lothian. Definitely, there is an increase in people using cocaine, and I think, I mean, I could be totally wrong, but we had quite a massive problem with MPS back in 2014, where East Lothian was just rife with people injecting bursts. I mean, we've got service users who've lost limbs, both limbs. And I think there's people still chasing that kind of effect, the euphoria they got from that. Plus, the quality of heroin remains really, really poor. And I think what's happening as well is you used to get your dealers would be separate. Dealers would sell heroin, other ones would sell cocaine. But now what we're finding is that you can get anything's readily available. You've got a dealer who's selling heroin and cocaine, and they're quite willing to make that journey to your home to drop it off. It used to be that, you know, you would go and access your drugs to the dealers, but they're running about sending 20 texts a day. I've got, do you want me to come now? And people who are starting to use both. We're also getting kind of deals. We're seeing deals, so you maybe buy 2 bags and get 1 free, or that kind of stuff. And the latest one that I heard, which was bizarre to me, was that people were actually getting a raffle ticket. So when they were buying their stuff, they were getting a raffle ticket, and if your number comes up, you could win a free rock. So these are the kind of offers that are being spread around by the dealers at the moment, just to keep people on their books, to keep people buying.
And we asked on a typical day, which it's very difficult to define. Obviously, that's tied to, as Pete was saying, about finances, and how many, if a person was injecting in that day, how many times would they inject? And 41 said 3 times or under, and 20 more frequently. And it tended to be people who, when injecting coke, would be inject more often. And obviously the risks that come with that, with injecting more each day. Do you find that clear, that it's becoming an issue?
Yeah, so it's interesting listening to what Elaine's saying, because we see such a mixed picture over compared to the east of Scotland and the west of Scotland. So I would kind of mirror that in terms of, we don't see the same level of injecting cocaine use in Edinburgh and Perth, but we're certainly seeing a lot more in the west. So we see a lot of, in a lot of our services, there's a real increase in injecting cocaine use. And you're right, the frequency is obviously a lot higher than potentially it would be through injecting opioids. And one of the big challenges that we often find is that a real lack of knowledge around safe injecting practices. So not ever having conversations around proper rotation of sites, or how to maintain your vein health, or, you know, just really sort of simple injecting advice. As we know, that comes with massive risk. So a lot of the risk that probably could be reduced quite significantly if people were provided with that kind of safe injecting advice might not be there in all cases. We're also seeing, with people using a lot of cocaine, a lot of real difficulties in mental health on the other side. So people having really, really difficult times with their mental health after using cocaine for a couple of days, a few days. So it's not just the risk of injecting necessarily.
The fact that the purity of cocaine is like over the last few years, now it's not the case. Well, here anyway, you're not just going and buying it. Now you're offered, like, do you want to buy it or do you want to pay the £100 and get the pure stuff? People tend to say, right, I'll spend £100 to buy the pure stuff primarily so I can inject it.
Yeah.
Where that never used to be the case.
So we're looking at other drugs that's been used as well. So predominantly it was benzos and to a lesser extent alcohol. In regards to alcohol, 34 people didn't drink at all through this study. So a big chunk of people did not touch alcohol. And only 7 people stated that their alcohol had increased. But the main thing that struck me was the benzo use. So 54 people who injected heroin, 40 also reported using benzos, and 32 stated that was street Valium.
Yes, aye, the increase in the amount of people using illicit benzos has it's dramatically increased in the last few years, and I think it's partly because, you know, the prescribers have stopped prescribing benzos, so people aren't able to access the real thing. So it's just opened up a massive market for illicit benzos. We've had, especially the city centre, since January, there's been a significant number of deaths due to benzos or polydrug use. And I think that's what we have to remember as well, that there is a massive increase in people using illicit benzos. But the problem is it's polydrug use. They're using with other drugs, so it's not just the benzos that are killing people, it's the mix of drugs. And I think for services it's very frustrating, and all we can really do, because there's so many different variants and the consistency and purity differs not only in batches but in individual pills, all we can do is really give out harm reduction messages, you know, start with low doses. If you're a different batch, take a tester first, carry less on you so that you know exactly how many you got and you're not just taking them consistently through the day, and always having the naloxone. So I think we just have to, for services like ours, we really have to hit hard with harm reduction messages. I think service users are really keen to know what's in the benzos. They really are interested. I have many conversations with the people I work with, and they're you know, if they've got a new batch or a new pill, they'll show me, they'll let me photograph them, they'll tell me the effects so that I can circulate that information to other users. But unfortunately, we've only really got Wedinos at the moment. So it would be fantastic if we could if we were able to test purity more often.
Safety levels is the problem, I think, as well as the polydrug use. Obviously, if you're using heroin, methadone, alcohol, and throwing benzos into the mix, I think it's the purity levels as well. A lot of people say to me, 1 week I bought 10 and they were rubbish, so I bought 20.
Well, exactly, and that's what ends up happening is you buy it 1 week, and like you say, Ken, what I needed last week was 10 times more than what I needed this week. And the sad thing is, it is because, like, presently the majority of street Valium seems to be this Atizolam, which is like 10 times more powerful than diazepam. The majority of users would use the real stuff. If you gave them a strip of proper diazepam and 100 of these Atizolam, the majority of us would take the real stuff, even though that the Atizolam 10 times stronger, but 10 times more likely to kill you. We would take the real stuff, and I think it's due to the fact that restrictions on real diazepam have been tightened that much. You can't get it, so people will go to the next thing, which is your street diazepam, or street valleys as they're called. But at the end of the day, there are no valleys at all. There are no diazepam at all.
Yeah.
And it's this Atizolam thing, and Aye, when you're mixing that with heroin, it's just a lethal cocktail.
We're looking at, I think there's 55 people in the study on methadone. And in general, I don't think it's changed. I think 9 people's doses went up and 6 people had went down. And obviously, I think we all probably come from a harm reduction point of view that that's a good thing. So the fact that 17 people are only injecting in one day out of 60 odds, does that prove harm reduction's working?
I think there's a few factors we have to consider. I think different services offer different treatment. So, you know, if someone's using on top, for example, quite chaotically, then services might only offer them buprenorphine because they think that's the safest option, and methadone might not be on the table. And I'm hoping when the MAT standards are implemented that service users will be given more choice on the treatment that they actually think will work for them, not what the prescriber thinks will work for them. There's a real push towards Buvidal out here at the moment, which when people do move over, I think they are seeing it as quite a successful drug, but I don't think pushing people onto that drug should be what's happening. Again, it should all be about the choice of the service user. I think as well during COVID, especially, there has been barriers to people accessing the prescription. A lot of people who are using on top are on daily supervised out here. In fact, most of them are, and that's causing people to fall off their scripts regularly. It's too much hassle to collect daily, or people feel stigmatized because they're having to go into a pharmacy where the consumption room isn't being used during COVID, so they're having to take their methadone in front of the general public. People were saying that they were still using on top because heroin's a different drug. There's no euphoria from methadone, so they see methadone as their safety net or their comfort blanket. They need that, but the choice, if they have the choice, they would still use heroin on top. I'm not sure if people would be using more if they weren't on a prescription. Probably they would, but I think we definitely need to look at more choice and offer our service users more choice on what they want to be prescribed.
I'm saying, do you think people are on their kind of optimal dosage, their correct dosage in general?
So I would just go back to Elaine's point in terms of are people given choice? Do they know what different medications are out there, and is that widely publicised to people? I think that overall the people I've been speaking to would say that they're on the correct dose, but I think that the reality is that people get different things from different substances. People use drugs for good reason, and especially in relation to the benzodiazepine use, they are effective in terms of reducing anxiety and supporting people with their mental health. I think the point that Pete had made around the difference between street Valium and prescribed diazepam, they're completely different drugs very often, but they are used because they're prescribed for anxiety, they're prescribed for sleep problems, they're prescribed for low moods. They give people the effect that they're looking for. I would say that people all are on, well, I've spoken to anyways, or certainly would feel they're on the right prescription, but I don't know if that's whether or not they've had that conversation with their prescriber, whether they know that there's different choices out there in relation to their medication that they might be able to explore. I think it really comes down to the relationship that they have with the support that's around them. If the relationship's there, I think that there's much more opportunity to have these more open conversations about what's going on in your life, because you trust the person and because you feel that you can talk to them about what is ultimately quite intimate parts of your life. And I don't think it's not all, and I think the MAT standards really express this, don't they, that it's not all about the medication, like it's about the holistic support that's offered for that person as well. So the psychosocial interventions, the relational based stuff, the trauma informed care, the psychologically informed approach. So while I think medication is of course important, I think the other parts of that treatment and that care package is of equal importance.
So we're looking at, there's a lot of overdoses as well. 19 people said that they overdosed or came close to overdosing. and 10 of them had to go to hospital. But on the flip side, 53 people out of the 61 had naloxone kits, which is absolutely brilliant. And 37 had received it during lockdown.
Naloxone's like totally imperative nowadays, and it's good that people are starting to realise how important and effective it is in saving lives. It's just sad that no as many people as we would hope actually can that this thing exists. I keep 3 kits here at my bit. There's one at my mother's just in case. It would be amazing if there was some sort of big advertisement campaign highlighting naloxone, showing how easy it is to save somebody who's overdosing, just by giving them a quick shot of that and phoning 999, how many lives it would save. Halfway houses and hostels or hotels or places like this, it should be imperative that they've got a story there, because these are the places where overdoses primarily happen. But places where people go when they've just been released of prison, these places should be trained on that.
I think it's educating the general public as well, because I remember seeing a thing in Canada where it was, because it's yellow and here, and it's basically an advertising to get, picked up with the police and searched. Whereas in Canada, they changed the whole text to be, this is a thing that you can save somebody's life. So it became something more that the general public would embrace and learn about, not just drug users, which I thought was pretty amazing.
I think I do a lot in naloxone training, not only with service users, but with services and family members of people as well. And I think that what we're up against is the fear of people putting a needle into someone. People are scared of carrying needles, and that's the feedback I get quite a lot. So if we were to start, nioxide hasn't been added to the framework here at the moment, but we did pilot it last year, and in terms of service family members and services who were reluctant to take it, it was a massive success, because it's not a needle, it's just given nasally. The cost is, obviously it's a lot more expensive than naloxone is, but in the long run, my argument is in the long run it's cost effective, because especially with the guys that I often given 2 or 3 a month because they're opening the kits to use the needles. So in the long run, if you're given a nasal, a nioxide, then there's no reason to open it. And if family members and other services are taking it and are willing to administer it, then I don't think you can put a cost on people's lives.
The next bit's about the IEP and the chemist thing, and really, in general, I would say that people are getting what they need. 49 people said they had no difficulties whatsoever in getting sterile equipment. The only negative thing I'd say would be 34 participants had reused injecting equipment during lockdown. But because I was involved in all the questions, I can say that it seemed to be one-offs, or 2 at the most. So I would just like to maybe ask Claire and Elaine, the changes that you've made, or if any, during COVID and lockdown.
Okay, well, basically the service I provide is assertive outreach, and it was set up pre-COVID to access and engage sort of hidden population of people who inject drugs, and to offer specialist harm reduction services within people's homes. And it was great for engaging people who are maybe using crack that were really hidden. When COVID hit, what we agreed initially would be a drop-off service. Obviously, we couldn't go into people's homes. So when I first started out, it was like taking bags of, I would do everything by text and phone, speak to people, and then arrange to drop off at their house. I would drop the bag off at the door and then run back to my car and sit in my car and phone them and say, that's me here, come and get it. And then, but obviously as the lockdown kind of progressed, the weather changed. I was able to have conversations with people in their gardens and stuff. They would be in their house, I'd be standing back in the garden. So it's not been ideal. When I was doing assertive before, we were offering a massive range of services, so DBST, naloxone, safer injecting, Hep B vaccinations, NFOs, wound care, referrals into OST and other recovery services and stuff. So, I mean, I'm not doing, certainly not doing what I was doing, but to offer some kind of service. And we know that IEP is a way of engaging people. I've just tried to adapt the service as best I can so that people are still getting some kind of service. I mean, in terms of our pharmacy IEP, in Midlothian, we have one pharmacy that'll give IEP equipment, and that's obviously for the whole of Midlothian. We have 3 pharmacy IEPs which cover the whole east as well, and East Lothian is quite rural. To be able to offer the service has been brilliant, and I'm just hoping that being able to get the amount of equipment out that we have been will reduce the risk of transmission for BBVs.
So what does it mean for you, Pete, to get that service?
It's been brilliant. Especially now they get delivered, because I remember I'm in Midlothian, and I remember when you could go to pretty much the majority of pharmacies in Midlothian to get equipment, and then all of a sudden it just started to be, well, you can't go to Pennycook now, for example, you've got to go there. And then they all started shutting down, and then before I knew it, everybody was having to go to Lone Head. And I remember personally going in there myself to be asked to come back another day. It's not really an option. So then I had to shoot away into Edinburgh, and then you would. I remember the next game week I checked with them, are you still offering that service? Hi, we are. And then you went down and they couldn't serve you because they were too busy. And it's like, well, you should really be treating me just like a normal customer. I shouldn't be coming in and your eyes being a nuisance because I'm asking for needles. And the fact that now it's just like a door-to-door service, phone up, Elaine, can I have this week, Thursday, it's there. So always think in advance, and that'd be a good thing to tell all the users, the service users as well. So I'm thinking in advance, just in case one week something, Elaine or whoever it is, Claire, can't come out that week. You want to have enough. You didn't want to have to be reusing.
Yeah.
Ken?
Claire, you describe what changes you've been trying to make in the Simon community.
Yeah, that sounds amazing. The postal IEP, delivery IEP. Yeah, so we've taken quite a shift, I suppose, during COVID, organisationally, but also within sort of our individual services. So we've shifted our whole drug and alcohol policy into a harm reduction model. So that's been quite a change for us in a lot of ways. And within our women's services in Glasgow, we started a safe injecting equipment trial. So we actually brought IEP in-house and started offering that service as part of our package of care for the women. And that's been really, really well received. And I think, picking up IEP is so much more than just providing people with safe tools and new tools. It offers up an opportunity to build trust and open up conversations. I suppose because a lot of our work is within residential services, and obviously we also do outreach, and we've got 2 of our hubs both in Edinburgh and Glasgow. Building relationships is absolutely fundamental to what we do, and I really see harm reduction as being embedded within that way of working. So we've been kind of approaching it, I suppose, from that very relational based place. And our new policy has really allowed us to kind of do that in a different way. And the naloxone stuff, in terms of the expansion to non-drug treatment services, has been a gift for us. So now we can supply naloxone as well as administer it in an emergency. And there's been a lot of amazing work done at our Glasgow hub around ensuring people are getting naloxone and having those kind of conversations, and just working more closely with partners, I guess, as well, to make that happen.
The other kind of couple of things that was just in regard to BBV testing, a lot of people had mentioned that, I think it was 37 people had asked for a test, and 32 got a test, and only 24 got the results back. Is that, I'll maybe ask Elaine that, is that just a problem with COVID at the moment, do you think?
Yeah, definitely. I mean, we encourage people to be tested every 3 to 6 months, and pre-COVID that was something that we done always. But it's COVID's just thrown all kinds of difficulties, and not being able to, obviously I can't go into people's homes at the moment, so BBV testing is something that has been really lacking within the service that I offer. Again, I'm sort of just hoping that by being able to keep the supply and demand of IEP equipment, that people haven't been sharing each other's equipment, but I know that we'll be having a real drive once we're able to get into people's houses on testing. I am able to refer to the bloodborne specialist nurse at the moment, and that's what I've been doing, but they've kind of only been seeing really sort of high risk people as well. But it's definitely something we'll be hitting hard once we're able to get back into people's homes.
And the other thing there was wound care. So 21 people had wounds, 13 had been seen and 8 hadn't. And is that something that you can deal with better in a, you know, in a hostel or whatever you want to call it, environment?
Yeah, so that's certainly something that we're exploring internally about how can we better support people if they do present with wounds, because people I feel are really reluctant to access mainstream services and health just because of previous experiences and maybe not feeling that those services are as accessible to them as perhaps being in our services or an outreach model. So it's something we're certainly exploring. We see, as you'll expect, a lot of wounds and a lot of a lot of injecting related injury. So we're trying to take like a kind of multiple approach to it in terms of offering people with safe injecting advice. We're looking at whether we can provide wound care packs in-house, and I suppose just upping people's knowledge so that if they do get a wound, then they can treat it as best they can themselves, and if they don't want to access mainstream. So we're kind of looking at it from a few different angles. We need to do a lot more in that space around actually providing people with information that they need so that they can inject safely, because that's a preventative measure in itself. If people are given that information, if they're offered that advice, then in terms of short, medium and long-term outcomes, it's going to be much better for people, you know, overall.
I just want to thank everybody, both today and for all your help during this, because it's been absolutely incredible, the help that you gave us, and I really appreciate your time and all your effort.
So thanks again, a really informative discussion. I know certainly I've been really impressed by the ingenuity of some injecting equipment providers and coming up with solutions to kind of make sure that they're getting new injecting equipment out there. So if I could ask Billy, Claire and Elaine to join me on screen for a question and answer session.
I'll just crack on then. There's a few questions. So Claire, what was the catalyst for changing to a more harm reduction model within the Simon community?
Well, I think COVID was a big driver for it. You know, when COVID hit, and like everybody kind of had to change their service delivery and design, and there was a recognition across the organisation that while we were doing some stuff in relation to harm reduction, we could be doing a lot more. So they generated the role that I'm in now, and really the purpose of it was to kind of build on and embed harm reduction across all our services. And I suppose on a wider scale, on the backdrop of escalating drug-related deaths and drug-related harms, just trying to kind of do everything we can do to make sure that people are safe.
Good. And Elaine, was the changes you made to your services purely driven by COVID, or was there anything about services not providing things? Or?
Well, we had to put the assertive outreach service in place pre-COVID, so we just really had to adapt it during COVID, where it became much more like a delivery service, and we made a lot more contact to people by phone. So we weren't able to do as many of the interventions as that we were doing pre-COVID, but it was kind of already in place. We just had to adapt it.
Right. And another question is, you deliver IEP to people's houses, which is obviously great in regards to harm reduction. Has there been any complaints or remarks from other people in the community about this?
No, I've not had any issue at all. I mean, the service is done quite discreetly. So, like I said, we arrange everything by phone. Send out a generic text at the beginning of the week on a Monday to everyone on my list, and then people get back to me with their orders. And what I do is I make up their orders in the building, so everything's bagged and ready to go. So it's just a case of turning up to their houses with the bags, where obviously you can't see anything through it, through them, they're black bags. So I just go to their doors and have a conversation.
I've got working from home issues. Somebody's in my door. I'll be back.
Do you think your home delivery will kind of continue after COVID, Elaine? Is that something that you're hoping to do?
Yeah, definitely. Yeah, it'll just get better, because we'll be able to, as soon as we can get back into people's homes, then we'll be offering a lot more of the safer injecting sort of stuff, and testing, or we'll be doing a real drive on testing, so we'll be offering a lot more. So it'll just kind of stay the same but get better.
That was my partner's Amazon addiction. So, Claire, similarly, has there been any issues with non-drug users about supplying IEP and the projects?
Oh, not really, actually. It's been really well received. So we've been trialling it in 4 of our women's services, like I said during the conversation earlier. But no, we've not had any backlash from people who aren't using drugs. They're just quite supportive of ensuring that people can access what they need. So it's actually been pretty positive in that sense. And we've done quite a bit of consultation with the women. So we've been delivering things like conversation cafes just to open up if there are any challenges or any worries or any concerns. So just kind of keeping that conversation going with people and with staff. So no, so far we've not had any backlash from people who aren't using.
So another one is harm reduction provision of IEP, a long-term policy within the Simon community now, rather than just being reactive to COVID?
Yeah, we hope so. So it was initially a response to COVID, because obviously when a lot of the chemists and things reduced their hours, there was a worry that people wouldn't be able to get what they needed. But because it's worked so well within the services, because it's been so well received, and because we've had great feedback from the women, then we would hope to continue it past COVID, because it just makes a lot of sense for us and allows people to get kind of what they need and to stay safe. And more importantly than that, for us, it really opens up conversations around safety and wellness, and builds trust and stuff. So yeah, it's been good.
And this one's for you both, but we'll go with Elaine. During COVID, what has been the biggest barriers, and also has it presented opportunities?
The biggest barriers, I guess, is actually seeing people in their homes and being able to offer the interventions that we'd like to. So, for example, BBV testings, there's not been any, because I can't get in people's homes, so we haven't been able to test. So that's definitely been a massive barrier for us. And I mean, we've worked ways around other things like safer injecting. We can sort of go through that with people on the phone, and wound care. I've like been taking photos. They've been standing in their door in their house, and I've been standing back and taking pictures of the wounds and stuff and sending it up to the wound nurse and getting feedback that way. So we have been trying to adapt things as much as possible, but I would say the BBV testing is the biggest issue. It's been great being able to zoom about when the traffic was really quiet as well. I was getting to see loads of people because there was no traffic on the roads. In terms of opportunities, I think again it's just been adapting, being able to adapt as quickly as possible. So we've been offering a lot more information and advice on the telephone or on social media. So our ADP were able to offer funding so we could give people phones. So we've been giving people phones, top-ups and tablets as well, so people can still stay connected. So that's been about the only opportunities it's given us. Get some money off the ADP.
What about yourself, Claire?
So I suppose in terms of barriers, for some people, like, you know, the move to phone contact has been really welcome, but for people who don't have access to phones and who are digitally excluded, it's been a real challenge, you know, to even find out what's going on with services and who's open and who's not, and just the general isolation and loneliness that people have been experiencing that was probably there before COVID, but's maybe been exacerbated with COVID, and that stay-at-home message where you're living in a environment, you know, in a homeless service. So it's there have been considerable challenges, I would say, for a lot of people that engage in our services, but there's also been tons of opportunity. I've really seen such massive innovation, partnership work, and people coming together just to do the right thing for people. All of these like things that seemed like they would never happen, all this red tape, it was able to get cut through to kind of do the right thing. So that's been great, and I really hope that that continues through COVID, and things like what you guys are doing, Elaine, with the postal IEP, like such amazing innovation, and, you know, really bringing services to people. So I'm really hopeful, fingers crossed, that those things continue post-COVID.
I'm trying to get used to getting questions coming in while I'm talking, so well,
Multitasking, Billy.
aye, that's on my game. There's a question, I think it's for Elaine. You mentioned that people don't want to take naloxone because of the needle. Do you think this is a training issue? Do you know of any cases where someone has died because someone never administered naloxone because of their fear of needles?
No, personally, I don't. I haven't encountered that. I mean, it's not really people. I've never encountered any issues with the people that I work with. It's more about being family members or services, non-drug treatment services who were trying to get on board to supply naloxone. They are the ones kind of with the issues around needles. Some family members are scared of needles, or just scared of the whole sticking a needle into someone. So that has been a bit of an issue. But I've never really experienced it with our service users, which is great.
How much time we got left? Norma, do you know? So I've got a few questions here. I'll throw one in anyway.
Yeah, we've got 5 minutes.
Oh, that's fine. And just another one, that's actually come up during the survey as well. Do you think the chemist offers proper, and this is not to get a chemist, but just do you think the chemists offer proper harm reduction advice on using needles and stuff like that? Or do you think that is specific to an IEP worker? I'll go for Claire.
So I would imagine that if the relationship's there with the pharmacist or the chemist, then those conversations could 100% take place. I would say if there was a private space that person could go and have that conversation, then it would make it a lot more accessible. In my experience, it totally comes down to relationships that you have with that person. Like, if you've got a good relationship with them, if you have built trust, if they trust you, then, like, you know, you can go in and have these conversations, because you're talking about, like I said in the video, like quite intimate areas of people's lives, and you add sort of the stigma and things that go on top of that. Like, it can be difficult for people to have those conversations. So I think, yeah, if the relationship's there, if the space is there, there's opportunities to have those conversations. In my experience, I wouldn't know if they happen regularly. If, you know, people just go in, they get their medication, they get their safe injecting equipment, and then they go again. If there is that space, that protected space to have those conversations. But I would say that they absolutely could happen if the environment was right.
Yeah. Yourself, Elaine?
I think COVID's probably stopped that happening in the IEP pharmacies that are available out here, because they're not using their consultation rooms anymore, so there's no private space for that to happen. And I know, speaking to a few of the people that I work with, it's actually created a lot of anxiety in them. So some people are having to take drugs before they even go to the chemist, because they fear the stigma and being judged. You know, some of them are from small communities and small villages, so they're having to go into the pharmacy and take their methadone in front of people, the general sort of population, which is causing some of them great anxiety. So I'm guessing that during COVID that hasn't happened. But I know pharmacies are trained, they are given training on safer injecting and having those conversations, how to deliver IEP. And if we do have issues, we have had issues in the past, and if we do have issues with any of the pharmacies, then we will go in and speak to them about further training, because service users are quite good at feeding back if they've had a bad experience in the pharmacy.
Right. I'll leave you this one because I know we spoke about it in the conversation and it was edited out. There's understandably a drop in wound care and BBV testing during COVID, and other suggestions from participants about the lockdown training, safer injecting training. I'll go with you first, Elaine. Have you any ideas or ongoing pieces of work that address these issues or encourages engagement as we need to pick up with people post-COVID, hopefully?
Well, I recently done a report for our ADP as well on polydrug use, and one of the recommendations that I suggested was to offer sort of low threshold style cafes, so that people, because there are many recovery groups and not so many for our people who are not at that stage yet. So I think it would be it's only fair that we offer something for the people who are a bit more chaotic. It would be great to offer something where they could come in and get a hot drink and something to eat, because we know through COVID, I know how many food bank referrals I've done and how many people are really struggling at the moment. So to get them in and offer them a hot drink and something to eat would be great. And then from there, offer maybe some structured sessions, short structured sessions on things like wound care, safer injecting, and that kind of stuff. I know it's something that I've spoke about with the service users, and they would definitely be up for that. Putting it together might be a bit more difficult, but yeah, it's something that I've definitely asked for the future.
I'll just finish with Claire. Have you anything similar?
Yeah. So we've been doing something similar to that, Elaine. We've been running conversation cafes in our services, so just really informal, conversation spaces. We've spoken about safer injecting, we've done overdose awareness after a particular incident, and just generally talking about our new harm reduction approach and what people think about it. And it's been so successful. And like you say, Elaine, put some hot food on, make it dead informal, non-judgmental and chatty, and people, are happy to engage and talk about what's going on in their life. So we've been doing that, and we're hoping to continue doing them because they've been great. We've also been using digital, so we've started a small digital trial in one of our services around using digital to promote harm reduction. So just signposting people to the right kind of advice and information, YouTube videos, so they can access it in their own time. So it's early days on that, but again, we're just kind of using the learning from COVID and people maybe having more access to digital than they did before. So we've got a few things that is going on just to build on that engagement and make sure people can access the information that they need.
That's great. Thanks again to the both of you. Thanks very much.
Yeah, thank you so much, Pete, for your contribution earlier, and to Elaine, Claire and Billy. Really appreciate that. So welcome back, everybody. So this is the second day of our Hepatitis Scotland online conference, living experience, patient and peer perspectives. So now we're going to watch a video where our volunteer peer researchers are going to share some of their experiences of being a volunteer. Paul and Jim, who are two of our research volunteers, are going to join us after the video to answer any questions you've got. So as usual, please submit any questions under the question tabs of the control panel. Thanks.
So we're just going to kick off asking you what your expectations were about volunteering with Hepatitis Scotland, mate.
In all honesty, I didn't know what to expect. I didn't really know what I was doing. So I didn't really have any expectations, to be honest.
At first, I didn't really have any expectations because I didn't know anything about it. But when I get into it, between the life I was leading and the volunteering, it was like night and day.
But I think through the interview process, I gained what I needed to know. So in terms of what it looked like on a day-to-day basis. So yeah, I think the expectations were quite clear before I started, and then through the training it made it really clear.
My expectations was that to become involved in a level that would also help me with my university work as well, because it was a requirement of the course. It's a fantastic company. I'd be able to get the opportunities, and I feel I have there.
All I had seen, I came to a wee changes group, and there was people there who'd volunteered, and they seemed to get a lot for it. So I was like, if they can do it, and they're volunteering, they seem to be getting help in the recovery, I'll just do what they were doing. And that's what I done. I just signed up on the dotted line, went along, got a disclosure. Never had a disclosure in my life. That went all great. Hadn't even been interviewed for a job in 1997, so that was on you, sitting there. It was quite scary at first, really scary. But it was exciting at the same time, and it was a great way to grow my recovery. It's a great way to discover what was inside and what was to come. So I'm very... If I'd put expectations on it, they wouldn't have been good enough. You know what I mean? If I'd put an expectation at the beginning, it far exceeded. 18 months down the line, my expectations are... It's just been an amazing journey. Aye.
How has volunteering made a difference to you?
I think volunteering's helped me in lots of different ways, but it's mainly I'm just trying to help other people. People gave up their time and tried to help me, so it helps me to learn new skills and how to interact with people, and it can't hurt me. So I want to get involved with that sort of stuff.
Oh, night and day, mate. I was sitting basically with nothing to do before I volunteered.
I think the biggest thing it's helped build my confidence. So it was obviously between work and just the discipline of going through the training, getting on the calls, just having a bit of input into the Zoom meetings, etc. So I think overall it's just helped my confidence.
It was the first time in recovery that was putting in action rather than around my recovery. So it was the first time I was sort of testing the mettle to whether I could get back to some sort of normality whilst working, if you like.
Again, do you know what I mean? It's about building confidence, and that, do you know what I mean? See, especially when you take drugs, right, and you're in a wee bubble you're in. Do you know what I mean? So when you put all that stuff down, yeah, as again, you've got to build, you know what I mean, and enlarge your own recovery. So with regards to that, right, it's done it that for me because it's also opened a lot more doors. There was education stuff online that I managed to do through this.
I'm in my ideal job as a recovery support worker in my local community, and I don't really think I would have got that if I hadn't been a volunteer peer researcher with Hepatitis Scotland. So it's aided me a lot. It's gave me a better grasp of things and just a general knowledge of what's going on and where I want to be.
It's made me level my own, really raised my own level of self-awareness. I'm highly aware now by volunteering through helping others. And that comes about by just making the step and being there. That's all it takes. And the rewards come in a far emotional way, yeah. But I felt it's made a massive difference to my well-being during this time, because I was very fractured for society and I'd been in here and studying all the time.
Did you find it developed any of your life skills at all through volunteering?
It's really helped me to kind of build new skills, develop the ones I have, mainly around about how to conduct myself in front of other people when I'm representing like Hepatitis Scotland, and run about sort of boundaries and safeguarding and procedures, and just being responsible and sort of yeah, I suppose all that kind of thing. It's helped me to be more sort of professional.
It kind of helps me with listening, because obviously when you're asking the questions, you're listening to what they're saying. Can it help me with that? Again, I bring up confidence because that's kind of a life skill. So it's helped me with my confidence. It's helped me with my listening skills.
I've spent a lot of time trapped up in that chaotic lifestyle where services and drug abuse, and I thought all that time was wasted. It seemed like I come into SDF and then I start learning, see all that experiences. I can now use these experiences I had working with others. You know, I can pass on. This is what I've done. That gave me confidence in myself. You know, something everything I've got is already inside me. You know, I might have lost a lot of time in life through abuse and chaotic lifestyle, but you know, I've got this now. I can pass it on. I can help somebody else through volunteering.
Amazingly, really, it was. I thought I knew quite a lot until I got out there and realised I knew nothing, and to basically start for like the first page of a book sort of thing and go through it again. So I think to find out exactly how things work and what have you.
It's about interacting with people again. So I think through lockdown, it's quite isolating anyway. And then when you're not working, your confidence goes quite quickly. So I think it was building relationships up with other volunteers and with Billy and Katie, who I've been involved with.
Because it's all right having a life experience, right? But when you're actually want to then work in this field, you've got to cross over and start learning everything that goes with that. And through all these volunteering roles, you can start picking all this stuff up as well as giving you the experience.
Yeah, the selflessness of volunteering, you know, not actually getting paid or anything for that was actually quite gratifying. You know, just doing the job.
What opportunities became available to you since volunteering with Hepatitis Scotland?
Getting to do all the online courses and getting to learn more about different things, and hopefully in the future that will open up even more opportunities. But so far getting to do that has been really good.
When I started volunteering with the SDF, I'd been enrolled for the addiction training down in South Ayrshire, a college course, so I'd done that hand in hand with that, and also I've went on to volunteer with Turning Point, and I've actually just got a job with Turning Point as well. Do you know what I mean? So as I say, it's just progress, and you know what I mean, and keep enlarging on it. Do you know what I mean? But opportunities have presented themselves.
Well, peer research is something that I've been interested in for doing it before. Stats. I've always been following a lot of stuff that's been happening with people's lives. So being able to get the opportunity to take the opportunity to be able to speak to people and gather their experiences, because that emotionally helps them, that emotionally helps me. So I was able to take advantage of that through calls, through peer researching.
There is a lot of training out there. So it was the initial training I did here for what I was volunteering for here, but equally the other training that's available. And just the engagement with people, I think, has been really big. You know, it's a great team of volunteers, and the Zoom meetings every week, just having that engagement with people doing the same kind of thing, and having that support, as I say, from volunteers and the paid people. And
recently, I've been employed with the Navigator program that I came through. I've been employed with them as a sessional worker, and there's no way I could have done that without having to have put in the groundwork with the SDF. Just even getting used to turning up in time, sitting here for an hour, or some cases 2 or 3 hours, and then getting off and sort of reevaluating everything. Do you find there was differences pre and post COVID? Did you find?
Yeah.
And what were the differences? Sorry.
Well, I think there's been a massive shift, really, and obviously we just spoke about there. We spoke about the shift in communicating. I'm very much a conversational person. I like there's only so much we say, and I'm really into how we interact with each other. And I just couldn't see myself grasping this way, or being on a screen all the time, somebody looking at me as if they were studying me. I felt that was going to be intimidating to me at first, but I've really enjoyed it actually.
With COVID and not working, you've got the time. I think what's great about volunteering is it disciplines you into, you know, a more timely manner with what you're doing with your day, because you've got to be on a Zoom call at a certain time. So I think that definitely helped. And then other things comes out of that in terms of who you talk to, what they're doing, other experience, and obviously the other volunteers who are more experienced certainly than me, just gleaning off their experience and what they've done and what they're doing. and a bit of hope as well.
I think it's been a dramatic change, so I think it's been good, but no good as in the sense like for the economy and mental health and that, but for me personally developed, I've learned a lot, and like the roles varies, do you know what I mean? Whereas before it would be like you've been somewhere like a college or something and you'd be doing the training one-to-one in a group setting. Now it's been online. That was a bit tough, do you know what I mean? I kind of struggled online. I like face-to-face meetings and contact and that, but I think they continue developing, especially with COVID's going on. It's been good. There has been a change, but definitely been a drastic change. But you learn that you're adaptable, do you know what I mean? You learn.
The last question is, what surprised you about your volunteering experience with Hepatitis Scotland?
I think the biggest thing, I looked at volunteering for a number of different organisations, and the process is similar but different. I think the positive thing for me with Hepatitis Scotland was the communication was very, very good from the offset. You know, sometimes you can get an email saying, oh, we're not, because of COVID, we're not looking to recruit volunteers, and then you don't hear for months, and it's that lack of engagement I found with Hepatitis Scotland from the very offset of the initial call, and then arranging the interview, that the direct contact was there, and I felt they were very approachable. So I worked with Billy and Katie, and Kate rather, and I felt they were approachable. I felt the process was quite direct, and the training was available, and it was available quite quickly.
I think the first thing that surprised me was the level of training we were getting. You know, some of the training that I attended over Zoom and that, but it was better quality than anything else I've done. So it was, the quality of the training was exceptional. What I also find is, and this really surprised me, was how involved we are as volunteers. You know, I thought we would be turning up and being given a script, and that was it. I had no incline that we would be involved in creating the questions, doing the interviews, and then following up with the seminars and that we're doing. So, I mean, that was brilliant to learn that, and brilliant to be a part of as well.
Aye, I thought it would be limited by doing it over the phone a lot, but I was wrong about that, and I suppose that's what surprised me, because I didn't think there would be as much to be gained by a telephone call, but there really was a lot to be learned from me, and there was sort of help for others on the other end of the phone.
Just the networking, the nice people I've met, you know, and they've treated me like, as I was saying, no a number, a person. You know, I've went to conferences, you know, and I've been on webinars, and I've spoke, and I've been treated like no somebody's just community addiction, no just a number, as I was in services. I actually feel as if I can put back into life now, and that surprised me. They've actually been able to get that out of me.
Thank you so much for that. Again, really good insight into what volunteering's kind of brought to you. And I just want to say this conference wouldn't have been possible today without our peer volunteer researchers, and certainly at Hepatitis Scotland, we're so grateful for your input. If I could invite now Paul, Jim and Billy to join me on screen for a live Q&A. Hi.
Hi guys. The first thing I want to say is there was quite a lot of questions that I missed for the previous, so for the people I'll try and get the answers to them from Elaine and Claire. But I'll kick on. I'll go with you, Paul, first. What inspired or motivated you to get involved in volunteering with Hepatitis Scotland or the SDF originally?
I think it was watching people before me, you know, other peer workers, and I'd asked them what they had done, you know, in their recovery, and I'd seen them in full-time employment now with the council and other places. It gave me the inspiration that this is a good pathway back into work, you know, community services. That was definitely what inspired me, looking at other people's journeys.
What about yourself, Jim?
Kind of same, similar journey. Being a recovered addict, it will be 5 years ago this month, so it will be, and it was part of that. And part of that was just basically the same as Paul says. It was getting involvement with people again, because I'd spent that long, many years in isolation. So that was kind of getting back into society.
Aye. And Paul, you'd mentioned that you feel valued as a volunteer with Hepatitis Scotland. If so, what way? What makes you feel valued?
I think it's just the likes of yourself, Billy and Kate, you know, like phoning me up. You know, I had a wee bit, I had to take a break and asking, phoning up if you're still okay, what's happening in your journey, you know. So I wasn't just getting left there, you know, I wasn't just volunteering and I wasn't seeing any growth in myself. And also the type of work we're doing. See, when you're working at the, and you're actually making a difference in people's life. Like we had health fairs and we're actually getting people through treatment, coming in with hepatitis, and then we're on the phone with them and seeing them getting well. So that's really rewarding. It gives you some your own personal growth to see people get well. So that's the things I enjoy and I get for volunteering.
Aye. Jim, do you feel the same way? You're valued.
Aye, I feel the same way. Aye, and it was good as well because obviously it involved. Well, since I stopped, obviously, what was chaotic in my life 5 years ago, I've been studying, I've been to college, and now 4 years later, well, and 5 years later, I'm at university doing the same thing. So that's really it was marrying up the experiences from before and the experiences that I'd learned in the last few years, and it's just see how that compares, and just I really enjoyed it though.
Good. Another one here is, have you felt it is difficult to remain focused and motivated as a volunteer during COVID? Things like isolation, family life, Jim, you mentioned education, other commitments come into your life. Do you feel it's been difficult to remain motivated? Because obviously you don't get paid, which is a big motivation for us. So I'll go for Paul.
Well, I've enjoyed being part of Hepatitis Scotland. It's actually broke up lockdown, you know, and we were phoning people. We were still working, volunteering during COVID, so we were phoning people and getting connection with other addicts. So see, sitting on the phone with other addicts, and you might be the only person they speak to on that day, especially at the beginning of lockdown, and sitting for 30 minutes on the phone, just asking them how their day was and getting survey results at them. I found that really rewarding, and it got me through lockdown, you know, just that connecting and talking to other people. So I've really enjoyed the experience through lockdown, and the Zoom calls and the WhatsApp groups, and I think people have really reached out and went that extra mile during COVID to, you know, to help it. I've enjoyed the experience.
Because that question, because I think that question kind of resonates with us all, really, whether we're paid or unpaid. It's just a strange time. What about yourself, Jim? Do you think to maintain motivation and focus has been difficult, or no, during COVID?
Yeah. To be honest with you, it might have suited some people. See if it was 10 years ago, it would have suited me perfect. Been locked away and told to stay away for like a couple of years and no want to interact with anybody unless I wanted to myself. But this time, it was a struggle, definitely. It was a struggle just to. But that was the best thing about the volunteering was the connection again. Once again, it was a reconnection with people, and it was the same back and forth across the phone. And that day, and I think that showed, because one of the figures I'm pretty sure was like one in the top 3 was to do with the peers, that the reason that all they went through their treatment, and just that engagement. It was definitely beneficial to both parties on the phone. And that gave us a motivation. Once you get a bit of engagement, then you've got a wee bit of hope going forward. And I think that works for the person we're speaking to on the phone as well.
Aye, that leads me to the next question is, and I was a bit unsure of this, if I'm being honest at the start. I'll go for you, Paul. Did you feel you were able to obtain a similar amount of information over the phone as opposed to in the community? Because I think that was a big fear for us all, that we wouldn't be able to do that. But what was your opinion?
Yeah, I found it definitely did. As soon as it was breaking say having a wee joke with the people as soon as you got on the phone with them, and that broke the ice, before you went into the questionnaire. And see by the end of the thing, you were nearly friends with them, that 30 minutes, at the end of the survey. So I think it was really good and helpful. And I was scared that we wouldn't be able to judge maybe somebody was adequate, if you want to say, because you're not seeing them eye to eye. So with valuable answers, but you could actually tell through their voices and how they were interacting with. So it was a really good experience. I found it a good way of working.
Aye, because some people had said, I feel more comfortable. I'm in the house in my jammies or my shorts, my t-shirt on, or whatever, and I don't need to go anywhere, and I don't need to come to a community centre to meet you to talk. So that was a kind of learning thing for me, that actually some people were more comfortable communicating like that. So Jim, how did you feel about that? About getting information for people over the phone? Did you think it was all right?
I think you're right in what you said there. As I said just to the previous answer, years ago it would have suited us. It depends where you are in your life and where you are on that journey, really. But because you weren't reading any non-verbal communication, so you weren't seeing any gestures or face, so even though we become accustomed to that through the wearing a mask and stuff like that, having that non-verbal behaviour there and just not having it, I thought was going to be hard. But see, it was actually great because through the tone of your voice and your experience of being a peer researcher, that we know that's how that model works, and we're able to engage a wee bit deeper and a deeper level with people through the phone. But that also worked through the phone, and you're able to still be able to pick up in that tone and that kind of pace of other people's call, and that feeling through the call still came through. So it did, which was really good. And it really did. I managed to gather a lot. I managed to gather a lot more effective communication and good information than what I assumed we would be able to at first, and that over that medium. But the great thing as well coming through all this was I didn't really know how to use all these Zooms and different calls and technology wise, and that has really enhanced my learning. I'm zooming a bit, so doing all that and the Microsoft Teams and stuff like that. I've always recorded myself with music, but it's having to watch yourself all the time is a different aspect. So it's learning all the technology, and the screen time has been good as well. That's one thing. I know it didn't relate to the phones, but at least it was a way of accessing people and a way of contacting people.
So both of you have volunteered in the community and post during COVID as well. Just what training do you feel you have benefited from the most? And that can either be in the community or online. Go for you, Paul.
Sorry, Bill. It was the peer research training and learning about boundaries, learning how to deal with people, learn how my tone of voice and how I respect somebody else is how I'll get respected back. Especially coming out of lifestyle or drugs and chaotic, so see sitting down and actually this is how we approach people, we give people respect, we keep eye contact. That was all the valuable things I learned, and now I can learn that. Whenever I move on to the next, I can use these skills moving forward. I'm just treating people with kindness, and that was the most thing I learned during all that training, definitely that.
And Jim, yourself?
The peer research training that we done swung back in again. So the boundaries, confidentiality aspects, the informed consent, all that kind of stuff. That's kind of stuff that I was really getting drilled into me the last couple of years, college and university, about safeguarding and confidentiality, stuff like that. So I was able to bring that to the table because I'd already done the training with the SDF a year previous. Well, it's 2 years previously. So that was good. And then once again, I was able to marry that up together. And then the learning was, it was good. A lot of learning.
There's a couple of. What has been the most fulfilling part of volunteering for you? With that either in the community or COVID? Go for yourself, Paul, again.
It's definitely been when we were in the community, just the health fairs, and just seeing people come in and getting tested, and then you maybe get it, and we can reassure them, look, 1 tablet a day. This person's through the treatment, it's done it really easy. We can show them that the step process right through, and then actually seeing people once they're through the treatment and seeing how much it has improved their life. That's what keeps me going when they do this type of work. Just seeing how we can that wee 2 hours of volunteering or 3 hours, how much it can affect somebody's life. Somebody gets through the treatment and they've got an opportunity to grow themselves. So that's the most rewarding part of this job, definitely.
Aye, I would agree with you. What about yourself, Jim?
Sorry, Billy, what was that one again?
Either in the community or online or over the phone with what they know. What's the most fulfilling part of volunteering, do you think, that you've experienced? Because you were involved in both as well.
I'd say definitely it's the feedback loop that you see being created between. It's through the peer research model, because if you've had that experience of being there and the person's relating to you, can relate to you easier. I was watching that in action. So that was, but that obviously gives me a lot more. I feel the gratitude for that more. So when I'm now able to give an inspiration onto people that I was never able to give before. And that's about that, aye. And it comes with like an all street degree you can't marry up, and the one that I'm trying to get now.
Right, 2 questions left. What advice would you give anyone else thinking of volunteering with Hepatitis Scotland or the Scottish Jobs Forum? Go for you, Jim.
Fantastic experience, can't plug it enough, because it's especially for people like me and Paul and people that have maybe been through a journey. It is a fantastic resource. The training's top notch, and the level of contact you're showing, and I think that was represented in that all the videos that we just seen there for the clips for everybody. It's not what I expected it to be. I expected it to be kind of maybe contact you every now and again, that level of involvement, maybe get you every couple of months or something. We're doing an event, but no, the contact's great, and I definitely the resources are there to be taken advantage of, because you've got 100 years experience for living a life that you used to have in the past, and now the peer research and the model there can offer you an experience and life skills and all different things that can update you. Now you want to get your brain back in order, basically, and get your life back in order. And it's a great way to do it. So it is.
What would you say to that, Paul? Just if you give anybody any advice about volunteering that's thinking about it.
Oh, definitely go for it. If you're like me, I was community services, so I had nothing for 20 years of my life, so it's a great way of putting structure into your life, a great way of keeping you grounded and starting to learn about yourself, and moving forward. So I'd definitely say get involved, take every opportunity, and it's a great way of meeting other people in recovery, a great way of starting to grow. So definitely just get on board with it. It's definitely the way forward.
And the last question is, I'll go for you, Paul. What are your future plans after your volunteering is finished?
It's full time. Maybe get back into some sort of education, and then hopefully get back into full time employment. I mean, hopefully I've been there by now, but had babies in between, so so I definitely back into full time employment.
Good. And yourself, John?
On the education front, I'll be able to finish my degree in integration of health and social care services this year, and well, that'll be through next year. But really,
I want to just start playing music again and get the clubs open again, and it's just that. That's what I want.
Right. Brilliant. Thanks to you, Beth, and thanks to everybody else that was involved and every peer research volunteer. Thanks very much. Appreciate it. Cheers. Thanks, guys.
Thanks so much, Jim and Paul, for joining us again. We really appreciate it. So we're getting close to the end of the conference, but before we close, we are going to share some hepatitis resources that have been created by Hepatitis Scotland that are free for anybody to access. So we're going to show a presentation from Kat, who's the e-learning development officer at Scottish Drugs Forum, regarding some of our e-learning opportunities in hepatitis B and C. And we're also launching a new hepatitis B booklet that will be available for free online.
Hi, I'm Katerina Verlakos, the e-learning development officer for SDF. Today I'm going to give you an overview of our recent e-learning releases and then give you some more details on our Hep B in Scotland e-learning course. Okay, let's get started. Over 11,000 participants have joined an SDF e-learning course in the last financial year. This was a massive achievement for us. This is the largest number of people we've had register for our e-learning courses in 1 year. We refer to people who join our courses as participants. We released 6 courses in 1 financial year, so that's from the start of April 2020 to the end of March 2021. In March, we released a motivational interviewing and brief conversations, followed by a How Are Your Sites, an introduction to injecting wound care in June. In September, we released the mini module Contraception Information for People Who Use Drugs, which was followed by the HIV Preventable and Treatable e-learning in December. We released this in December to mark World AIDS Day. Our final 2 releases were What's Happening on the Street with Benzos in February, shortly followed by our newest e-learning release, Hep B in Scotland, which was released at the end of March. Today, we're going to look at our newest course, Hep B in Scotland. The course aims to raise awareness and knowledge about Hep B. The concise course can be completed in 2 hours, or alternatively can be completed in separate sittings to provide a fully flexible learning experience. Dr. Eric Chen helped develop the course. He has written the e-learning in a conversational and informal tone, so the content can be easily understood. This video will give you an overview of the course. You've heard what I've got to say about the course, but let's hear what our course participants said. They said they're going to be able to discuss Hep B transmissions and give harm reduction advice, but also inform people about a Hep B vaccination. We asked our participants if they intended to make any changes to their practice after completing the course. Here's what they said. They're going to encourage clients to go and get tested more regularly. They're also going to be more confident if a service user discloses any issues surrounding this, and would encourage them to seek treatment and help. This course was released alongside a Hep B booklet, which was created by my colleagues in Hepatitis Scotland. The booklet can be found on the SDF website, and my colleagues will also email you after the event with links to the e-learning and booklet. We also have a Hep C and new treatments e-learning course. This aims to raise awareness and knowledge of Hep C, and importantly highlights the new treatments for Hep C. This can be completed in 2 hours. You can register on our SDF website, which is shown on the screen. And finally, let's see one quote from our e-learning participant. They said, this course explained Hep C and the new treatments a lot easier than the leaflets I read about them. Easy to learn, but also remember. Thank you for listening, and you can find the e-learning on the SDF website.
Thanks for that, Kat. So as Kat had mentioned, we've recently published a hepatitis B booklet. It's got some introductory information about hepatitis B and what it means to live with hepatitis B. It's really aimed at people who've been maybe recently diagnosed with hepatitis B and anyone who works in services that's working with people who are living with hepatitis B. We've got an online version, but also get in touch if you want some printed materials. So sadly, that's us at the end of the Hepatitis Scotland online conference, Living Experience, Patients and Peers Perspectives. Really want to thank everybody who's joined us over the last couple of days. We're going to shortly be sending out an email to all attendees with links to the online e-learning and information about the hepatitis booklet. There'll also be a short evaluation attached, and if you could complete that, that's really, really helpful for us to kind of look at how we go forward in the future. Both sessions of this conference have been recorded, and you'll be able to get it on Hepatitis Scotland's YouTube channel. Finally, I just want to say a huge thank you for everybody who attended today. Special thanks to Billy and all today's speakers, and a big shout out to SDF Comms Department, who have done the really difficult bits of this as far as I'm concerned. I hope you've all found it really informative and engaging. Thanks so much. Bye.